Hi, everybody. Here we are back at it, and we're going to be going through the intro for knee conditions right here. And of course, we have to review some basic content on this. So of course, we're in the orthopedic conditions manual right here. Any condition that you want to find, you can look inside the front cover. But a couple of key things to get. In your knee exam, we know how we run this, right? It goes anatomy, assessment, and then actions on a condition-specific basis. There's a couple of key things that we want to go over here, though, of course. You should be able to already at the start figure out what pathology is going on for your clients or patients simply by where they have pain, like a Baker cyst on the back of the knee. The pes-ansarine bursitis, you should recognize where the pes-ansarine is on the medial side of the knee. Chondromalacia patella, infrapatellar tendonitis, Osgood-Schlatter's over that tibial tuberosity, right? LCL versus MCL tears versus meniscus tear. Look for that joint line tenderness. So some interesting stuff there for you to start with when you're asking your basic history questions. Watch for the person to point iliotibial band syndrome if it's snapping over the lateral epicondyle. You can see there. Watch for your client to point to where the pathology is. But I hardly ever cite an article directly. I shouldn't say that. We do that fairly regularly, but this one in particular from the British Medical Journal strongly recommends against arthroscopy for nearly all patients with knee OA or meniscus tears. And this article was so well written, the strong recommendation against actually suggests that further research is unlikely to alter this recommendation. So when you have a respected group of researchers that make these kind of statements, they tend to affect all of our medical outcomes. And this is great for a lot of patients because it shows 5 years and 10 years out, the outcomes are effectively the same. So the requirement for the surgery in the vast majority of cases is not warranted. So excellent for us to see that. Although there are still going to be cases where it might be warranted, but again, you would co-manage with somebody else. So fantastic. All right. As we progress through, you should be able to identify all of the bones. Knees are excellent. I love assessing knees. They're easy to figure out, easy to rehab. They're actually pretty good to work on. Nice, big, strong joint that we have lots of opportunity to work on. But if you wanted to quiz yourself, remember we have videos on all of this stuff where you can quiz yourself, or you can just cover these up right here and say, can I label number 1, number 2, number 10, number 11, all that good stuff. And if you know your anatomy, you can see this on X-ray and identify those same structures, especially in this case, we're seeing progression of degeneration of that joint, okay? In severe cases, yes, actually surgical interventions may be warranted. But again, looking at this knee, I cannot correlate the amount of pain that this person actually has with that. It's more on a pain basis, but we'll get into that as we get into the DJD and other conditions of the knee specifically. But here we're getting through our basic intro. You should remember the basic orientation of the ligaments as well. You should know the LCL, MCL, ACL, PCL, infrapatellar tendon, all of that good stuff. You should know that there's a fat pad. And if you have done your cadaver dissections, you know that even beyond this, there is layer upon layer upon layer of connective tissue all the way around the outside of this knee as well, giving significant stability. All right. And we also label all the specific ligaments that people would know, connections of the bursa down here as well. Then we move on to the muscles, and you should know all of the muscles that cross the knee joint and the hip joint and the ankle joint as well if you're doing an evaluation here. Again, we have separate videos on palpation, on muscle testing for all of these you can find, or I would refer you to the muscle manual that you can see right down there. Or I would refer you to any of our other videos on the Pro Health Central website. What else do we see? You should be aware of the screw home mechanism. The last 15 degrees of extension rotates the femur medially or the tibia laterally, and it locks the knee into place. A lot of people don't remember this, that knee extension is the tight packed position of the knee. So LCL, MCL, ACL, PCL are all tight in that position right there. As you flex, these ligaments become more lax. So when we're standing, that last 15 degrees of extension locks your knee in place, puts you into a low energy state when you're standing. Other key things that you might want to be aware of around here would include patellar subluxation versus dislocation. Almost always the patella goes laterally just because of the pull of vastus lateralis and the smaller shape of the lateral femoral condyle or lower groove on that side. Got some pretty good cadaver dissection video where we can see some of that stuff. All right. What else do we have to get? We get into knee kinematics that you should be aware of as well. So the knee is a modified hinge joint is what you're looking at. The largest, most complex joint in the body. I couldn't think of a much worse design. If you actually look at the real shape, it's having a flat ball or almost round if you look at the top of the tibia, because it does have a little bit of convexity to its shape, with another ball balancing on it with your femoral condyles. And now make that stable, put all your body weight on it, and jump on one leg while you do that. So very prone to injuries here, obviously, especially when you're looking at a lot of athletes who are wearing cleats. I had one athlete in particular. He said wearing cleats in sports is a performance enhancing drug, basically. And I couldn't agree more, because normally where your feet would actually slip out and slide out to prevent that pressure on your knee, now the feet actually grip and that pressure goes to the next point in the kinetic chain and you feel it through your knee. But I digress. What else are we looking at? Range of motion, roughly 150, 0 to -5 degrees. You have pretty good internal external rotation, 20 to 30 degrees there typically. The knee must be flexed, however, to do rotation. Back to the tight packed position. When the knee is straight, it is locked in position. So you are not getting rotation with it. The rotation that you see, and especially junior students get tricked by this all the time, is from the hip joint. If the knee is flexed, then your biceps femoris and semitendinosus and membranosus can rotate your knee medially and laterally. You should know the muscles that do each of those actions as well. So we give a list there. Tight packed position, resting position, end feels, kinetic chain movements, where the patella actually contacts the knee, depending on how much flexion you're doing. Pretty simple. As you flex your knee more, the patellar contact goes more posterior on the femoral condyles. Patellofemoral loads as you are moving. And this is an interesting one here. Walking, a third, 30% of body weight upstairs because you have to flex the knee more, way more body weight. Downstairs, you're taking even more because that eccentric loading. Squatting even more, deep squat 12 times. And I read one study that talked about triple jumpers taking about 15 times body weight force into that patellofemoral joint. You should also know the Q angles here. So your angle for women is less than 22 degrees or greater than 22 degrees. I should say less than 22 degrees, and for men, 18. So you should know 18 to 22 is your rough range right there. Then you can have genu valgus or genu valgum. And what happens there? The valgus means the distal bone points lateral, or you might know it as knock-kneed. If you are knock-kneed, that's going to put more loading compression on the lateral side and more stretching tension on the medial side. Versus if you have a more varus or varum shaped knee, it's going to reverse that. But we'll come into those once we get into those conditions. What else should we be aware of? Just the mechanics of movement as you jump or flex your knee. A lot of people forget the patella pretty much stays where it is. People think the patella is what raises up. And it does a little bit in a standing position. If you contract your quads, it pulls tight. But as soon as you start bending your knee, the patella gets tight. And then the rest of the movement is from the femur actually moving in relation to the patella. That patellar ligament holds you in your maximum point of height. It doesn't actually move anymore beyond that, unless you have a nasty injury of bilateral rupture of the infrapatellar tendon or ligaments. Also, I loves me this picture right here because it shows you all of the receptors that are located inside of joints. So you have postural receptors, dynamic movement receptors, inhibitory receptors, and pain receptors that exist inside of this joint. Especially important in the lower extremity for our overall proprioception and balance and function and movement. And you'd have the same receptors in the ankle, around the hip, around every joint in your body. Just tends to be a lot more of them around the knee because of its poor design and instability potential. What else? You would do a full knee exam flow. And in this knee exam flow, you would see key questions that you would be asking, like specific mechanism of injury. Did you hear a pop or a snap? Because people can often hear tendons snap when they do those actions. Did you have pain going up or down stairs? Any swelling? Where is the swelling? And what type of shoes, running surfaces? Those are good key questions as well. Of course, inspection, you will do a fracture screen if it is a risk there, and then palpation of all of these structures. And again, I would refer you to all of the videos on the website here where you can see palpation in detail of all of these structures should you forget some of it. Functional assessment, squats are where it's at. If you can just get the person to squat down and get themselves back up, that is a good functional capacity assessment right there. Range of motion, again, we can see, you can check myotomes super quick, but a squat kind of checks a lot of that, especially if you get them to stand up on their feet or on the balls of their toes. Neurovascular screens if you're doing a full exam. And then I give you orthopedic tests, special tests indicated by pathology as you go through. And of course, Ottawa ankle rules looking to rule out fractures as well. You'd apply these up into the knee. I believe there's Pittsburgh knee rules. Forget the specifics on that, but there is specific knee rules. But again, if you're in doubt, watch our video on fracture screen or go onto YouTube, and the fracture screen that I teach you, you can apply to any joint, any bone in the body. All right, and then we have our clinic exam forms. Why would we make up these forms? These forms are made so you can remember and have a checklist, playbook, cheat sheet that you can work through all of the things that you would do as part of a detailed evaluation of the knee. And these are literally used by thousands of docs. Again, you can find them on our website. Okay, then you're going to go into your palpation. Again, check out the videos. It's just a reminder to say, hey, we got videos on all this stuff right here. Then you're going to go into active range of motion. And when you do active range of motion, again, we have video to show you how to do this or remind you how to do it. But you're also going to think about what muscles are activated, tissues are stretched, and tissues are compressed with each of those movements. What are my potential pain generators? What could be compensating factors that I have to look at? As we continue our progression and wait for our website to load, ka-chunk, you can do goniometry if you wanted, relatively easy around the knee. But again, I would really only do this if I had a litigative case or like an insurance case that I was working on. Usually you can tell what good functional range is as your experience gets up. Knee passive range of motion. Your assessment is therapeutic. So get this person moving around and see how they can actually tolerate those different movements. Checking the unaffected side first, of course. And then the same thing for muscle testing. I would refer you back to the muscle manual or all of our videos on specific muscle testing to, again, gauge specific muscle function as best we can during manual muscle testing. All right. And just some simple ones here: vastus lateralis, medialis, hamstrings. Usually those are going to be your base tests right there. All right. And then, of course, our key special tests that we might perform. This is not all of them. I would refer you to the orthopedic conditions or orthopedic assessment text on this. Or again, there is video of all of this on our website. McMurray's has pretty good research behind it as a test overall. That's where you're compressing in, flexing, extending the knee, and doing internal and external rotation. I have found that if you are a smaller practitioner, this one is often difficult to perform. And when I ask students and doctors to do it after graduation, all of them have a difficult time doing this one. So usually not my first go-to. There are other ones that you can do. Patellofemoral grind is good. Apprehension tests for patellar dislocations are good. What else? Anterior and posterior drawer would be great. Even a Thialces test would be good, but this kind of gives you a quick introduction to some of these that you might do. Lockman's is a good test as well. All right. And then, of course, knee evaluations that you would be looking at right here. So yeah, there's the Pittsburgh knee rules and Ottawa knee rules that we should be aware of. So if you are taking x-rays in your own practice, this shows you the basic setups. This shows you how the image would actually be taken should you be trying to interpret these. I am not a fan of reading other doctors' radiology reports until I have done my own evaluation of the imaging, because you become biased. What happens is, if I described a picture and you described a picture, we would both describe it in a different way. Well, that's what a radiology report is, except the radiologist has the disadvantage of not actually seeing the patient for a clinical exam. So what I want to see is the actual imaging itself first. I'll look at it with the patient in my clinic, just like you can see here behind me. I have a big screen in there so we can toss stuff up there so people can watch it. And then I'll walk them through and explain it. Then I'll look at the radiology report and say, oh yeah, is there anything that I missed or anything else that I want to add? There are studies that show extremely poor reliability between one radiologist and the next for clinical significant findings and what's actually reported on radiology reports. Okay, so knee x-ray only required for knee findings if, and this basically goes back to a fracture screen. Are you older than 55? Did you have significant trauma? Is there exquisite point tenderness? Do you have dark black bruising? Are you inability to weight bear on that side? Do you have limited range of motion? As you have each one of these items and you start checking them off, the likelihood of you having a fracture goes up, then yes, I might do imaging. But in the vast majority of cases, imaging is not required. Yeah, the age thing, you're looking at risks of osteoporosis and other stuff there. So we know that as tissue gets older, it becomes more fibrous. You're more likely to break bones and you are to damage ligaments in older people. Yes. And then here's the Pittsburgh rules as well that you can look at. Of course, knee evaluation. I mean, MRI is great. It can show you a lot of good stuff. Like here, we can see an ACL rupture. It's actually fully gone right there on this. Because again, the nice thing about looking at the imaging, you'd be looking at the planes of cut as you went through it. This film right here is showing us an avulsion fracture of the medial intercondylar eminence. That would be a tricky one to pick up, but again, something you have to look for just on that A to P view. But just basic imaging if you needed to look at it. And then we get into our pathology. So that'll be our quick introduction to knee joint assessment. Of course, more specifics are located throughout the website and the books to back this up. And we will see you in the next video as we start getting into conditions of the knee. All right. Thank you very much.